And thanks to you for joining us for today's webinar on building high-value care bridges, brought to you by the AHA's Physician Leadership Forum. I'm really pleased today to have Dr. Christopher Moriarty, Assistant Dean for Healthcare Value and Associate Professor in the Department of Internal Medicine at the Dell Medical School at the University of Texas at Austin, joining us. Dr. Moriarty speaks internationally on topics related to educating clinicians about healthcare value and how to implement high-value care programs. So without any further introduction, I'm going to turn it over to Dr. Moriarty to tell you all about it. Dr. Moriarty, the floor is yours.
Thank you, and thank you to the AHA, and appreciate spending this hour of our afternoon all together with you guys. So what we're going to talk about is building high-value care bridges between the educational and clinical environments. First, some disclosures. I do get royalties from McGraw-Hill for the textbook Understand Value-Based Healthcare, and a lot of the work that I'll be sharing today has been supported by grants from the ABM Foundation, the Macy Foundation, Episcopal Health Foundation, and ACGME. So a little more than a year ago, I was sitting in my office in San Francisco. I worked at UCSF as a hospitalist where I had trained, and I felt like I had the best job in the world. I had a great boss named Bob Wachter, who many of you may know. We were starting to do a lot of work in value improvement and getting more traction in that. And I got a phone call from Clay Johnston, who had been at UCSF but had moved to Austin, Texas to become the dean of a new, not even existent yet, medical school called Dell Medical School at UT Austin. And he asked if I would consider coming to check it out. And having grown up in California my whole life, the prospect of moving to Texas didn't sound like something that I was particularly interested in, but I thought I would come see what was going on, and came down to Austin and learned a lot of things during that visit that was really compelling. And the first was that the people of Travis County, where Austin is, had voted to raise their own property taxes to help support the medical school and to help support creating a healthy city in Austin. And so Dean Johnston said to me, you know, the people of Austin have really committed in us, our community is committed, and so we're committed to them. And how we're going to measure success is extremely clear. We have to provide health to the people in our city and create this a model healthy city. And as I walked around with him, and literally the buildings being raised from the ground, the medical school, new hospital, the clinic buildings, the health discovery building, we started to talk about the opportunity to really build value in from the foundation of this medical school in both the clinical and the educational enterprise, and to create a role that would be responsible for doing that. And so we talked about the opportunity to create a role and a title that I ended up taking, which was an Assistant Dean for Healthcare Value. And you know, when you make up a title, you get to be the first in the country of that. So I'm the first Assistant Dean for Healthcare Value, but I hope not to be the only. And what I hope to do today is to really talk about the importance of connecting, bridging both education and clinical value improvement activities. I imagine that those of you on the call, some of you find yourself more on the educational side of the house, some of you more within, and probably more of you within clinical operations. And that's fine, and maybe you'll find more of the tools in the first half or the second half of my talk today more specifically valuable to you. But I hope no matter what to leave you with the sense that these need to happen together, that if we're going to make progress in value, we need to really think about how we are coordinating and bridging and implementing across both education and clinical operations. And the reason I tell you my story is just because I think it's really illustrative. It's the story of getting a trainee involved. So when I had done my training at UCSF and I was a resident, as I mentioned, I worked with the smartest people in the world, and I thought I could ask them anything, and they would know the answer. But there was one question. When I would ask anybody within the hospital, how much does that cost? How much is that going to cost our patient? How much does that cost our hospital? I always got the same response, no matter who it was. And it was clear that nobody seemed to know. And this was 2010, and at that time, Molly Cook, also at UCSF, had written a piece in the New England Journal about medical education's responsibility to start thinking about cost awareness. And thankfully, because of the environment I was in, I was able to work with mentors and learn how to start to address this. And we started by implementing a cost awareness program at our hospital where we just started teaching about cost and started asking questions, and we started a noon conference, and that grew to then help contribute material to the ACP's National High Value Care curriculum that's now freely available. And then as I started to graduate residency and went to take my faculty job, I remember Bob Wachter told me, you know, you're a resident leader, that's great, but it's kind of like being a childhood actor. It doesn't mean you'll make it in the real world. What are you going to do? You know, you can't just talk or teach about value. You need to do something about it. And that's what I think we should talk about today, is what are we going to do about it? How are we going to connect and bridge education and clinical value improvement? So first off, I think just to get this out of the way, there are many different definitions thrown out there, all kinds of equations. And when I'm talking about value today, I'm going to use the simple definition that value-based healthcare is considering outcomes that matter to patients over total cost of care. So what are the outcomes that we achieve that matter to patients with consideration of how much does that cost? So now I'd like to do a quick poll for those of you on the call. I'm curious, how many of you have a educational or clinical program focused on value currently within your medical center, within your medical school? So you should see here on the screen, and you can click the buttons, yes or no. Do you have an education or clinical program focused on value? I'll give a few minutes here. Wow, I'm seeing a lot of no's come in, which I'm going to interpret that as you're here on the phone to learn how to do this, I hope, or to find out about tools that you can implement locally. Certainly, we know there are many barriers to this, to implementing value both educationally and clinically. But I think that, and by evidence of you being here, I think it's becoming widely recognized that this is a critical component of how we're going to deliver care, particularly in hospitals. And those in hospital administration and hospitalists have a key role to play in all of our local environments, but nationally in advancing the goals of providing value to patients. So thank you to the about half of you on the call that have responded to that poll. And so what I would like to do is share first the argument for, and I'll do this briefly, but the argument for why we must integrate this into education. And then I'll share a number of tools and models that we've developed on the education side of the house and then on the clinical operations to combine these two. And the first is there's a lot of evidence. I've got, just a few of the references listed here, but the environments in which medical trainees learn have lifelong effects on their medical practices. Those trainees who do their residency in intensive settings where they're taught where the environment is to order lots and lots of things, if you follow them out into their careers, that practice tends to stick with them. And so what we teach and what we show and what we model has lasting effects, both in quality and in value and resource utilization. And we need to start upstream. So although many folks are starting to recognize the need to teach about value at, say, the clinical level, to start teaching our physicians about the concepts of value and the definition and how we address it, and many as well recognize that we should be doing this in residency training, and there's been some tools that have come out. I've mentioned the ACP curriculum for residents. I really would argue that we need to look all the way upstream. We need to introduce this into the very way that we teach healthcare professionals about their job. And I would argue when you teach a first-year medical student about value, it's not about specific things. Certainly it's not about teaching them macro or policy that's going to potentially change by the time they are in practice, but rather it's about giving them an entire perspective. When you take that red pill of learning about value and seeing the world in how are we improving outcomes for patients over total cost of care, I believe it really shifts the way you view everything you learn. And so in first-year med school, when you're learning about chest pain and how to work it up, if you've been introduced to value, you think very differently when you see all those lists of potential stress tests that you can get. You ask different types of questions. And we need to start upstream to do that. Now, like I said, I know many of you are in clinical operational roles, and the argument that I hear often is, well, fine, but we have a problem now, and if I'm teaching a first-year med student, that's not going to really show effects for 10 years, 15 years, and that's absolutely true. So I don't think it means that we don't do anything currently, but we need to recognize that unless we really get in upstream and have the ripple effects from trainees' learning experiences, we're not going to have the sustainable change that we really want to see. If you get to a medical student, those students' learning will reach all corners of our healthcare system. When I hear the criticism about that this is the long game, I like to think about the old proverb many of you have probably heard, which is, when is the best time to have planted a tree 20 years ago? When's the second best time today? And I think we're facing that right now. Sure, it would have been great if we had done this a long time ago, but now we really need to address this need. And we know that this is clearly a gap. There are many examples of this that medical training programs lack, and you guys just showed us, lack formal and informal mechanisms for training health professionals. And the Institute of Medicine, MedPAC have all identified it as a critical need within healthcare training to think about value and how we're providing outcomes and considering costs. So we need to bridge that gap. We're the ones who need to bridge what we're talking about in the educational enterprise, what we're recognizing as a need, and what we're actually doing in our clinical environments. And so this is the argument, I believe, for creating bridging leaders and bridging leadership roles that are specifically responsible for bridging this gap, for understanding what's happening in the clinical environment and also understanding what we're teaching and making that more continuous. And so what I'm going to do is look at two pieces, two sides of this bridge. The first is to talk about a robust value-based healthcare curriculum for all that we have built and options available for everybody to use. And then shift focus into how you create those value improvement initiatives within the clinical learning environments. So we just released in June this year, Discovering Value-Based Healthcare. They're interactive learning modules, and I know online modules can be a dirty word. We got a $1 million grant from the Episcopal Health Foundation to build out this program, and so we spent a lot of time and money and worked with an Institute for Transformational Learning to think about how we make this so it's not like traffic school. So it's not like those things that people just have to muddle through, but rather is interactive, engaging. And so we're creating, so far we've got on slate 10 complete modules that will cover the gamut of what we believe every health professional should know about healthcare value. But currently we've released the first collection, and that collection we call Introduction to Healthcare Value. It's composed of 3 modules. Each take about 45 minutes to complete. It's available completely free of charge, and in fact, we now offer free CME credit for anybody who completes the 3 modules. And we also offer a free certificate from Dell Med School for completing the Introduction to Value-Based Healthcare. And what we've done with these modules is we've thought, if we're going to give a free introduction to folks, we want it to be, what does every health professional need to know, whether you're a first-year medical student or a practicing physician? What is it that you need to understand? And in order to do that, we've created a few critical components. The first is that we start every module with a clinical vignette. So we've created these videos, and it's particularly important, we find, for young trainees who perhaps don't totally know the system yet, to see where the gaps are. So in that first module, we have a vignette showing a a standard, case of somebody who it really illustrates the lack of coordination of their care, the duplication of tests, the confusing communication from the health from her physicians, and so you watch these vignettes, and it helps ground it into our day-to-day clinical lives. And then what we do is we actually create a dialogue. So after watching the video, we ask folks to respond and tell us what problems they saw, and then we collect those and we show them. So after you submit your response, you get to see the responses of others from across the country, and we believe this helps create a community of learners, so you can see others are doing this with you, as well as create a sense of accountability, right? Because you can't just type gibberish or it's going to show up with your name next to it. And so we've thought about how do you create this community. We also have the modules interactive, so you can click on graphs, and it will show you some specific examples. We'll link out to different topics, and we have exercises that the learners can do. In each of the modules, we have a care redesign case. These are loosely based on the idea of the Harvard Business School cases, where you look at an institution that's implemented something, give a background on it. So in this first one, we looked at University of Utah and really focused on their value-driven outcome tool, explained what it was, provide supplementary resources for those who want to dig deeper. And then after the care redesign case, we do an exercise, the learners do an exercise to help illustrate an aspect of what we learned. So from the value-driven outcome tool, we've created a mock value-driven outcome tool that looks much like the one at University of Utah, using real data actually from Texas. And we walk the learners through an exercise to make sure that they understand how to use it. And so they go through, they see how to identify opportunities on the scale of an entire health system. And then we zoom in to look at actual patient level data, and we provide patient stories for each of these to really tie it back and show here's the opportunity we have to tie hospital operations to your day-to-day work, and how you can identify gaps, and how some of this variation is warranted. So, this middle-cost patient had warranted reasons for their variation, but others are really due to systemic issues or just due to individual clinician issues. In another example, in the third module, so maybe I should mention, so Module 1 really provides an overview. Module 2 gets into measuring what matters and describes outcome measures versus process measures, talks about patient-reported outcome measures, explains the importance of that. The case is about UNOS and how they completely redesigned their outcome measures and the results they've achieved from that. And then the third module is about understanding costs in healthcare. And we get into charge masters versus cost versus price. We get into different accounting methods, so time-driven activity-based costing. And we give a care redesign case of MD Anderson, and we talk about how they implemented TDABC within their clinics and some of the results they got. The activity we provide after that is a description, if you kind of see here, I know it's small, but a clinical case where each time you click on one of the blue areas, one of the services that we provide, it adds up on the side like an Amazon shopping cart. And so the learner can see how each of these things add up. And we then provide the opportunity to see, well, what if Ms. Chen has insurance A? What does that mean for her out-of-pocket costs? What if she has insurance B? What if she's uninsured? And then we provide a TDABC next to the whole thing that shows, well, what if they did real cost accounting, not using charge master prices, but figured out how much this actually costs. And so I think it's a pretty cool way to really teach folks and get them to experience these lessons of why costs matter in healthcare, what do the different terms mean, how can we think of more rational cost accounting, and also how does it affect the patient in front of us. And don't abstract this just to a GDP level or a national level that oftentimes does not capture the hearts and minds of those of us who put on white coats and see patients most days. So this, as I mentioned, is available for free. It's here on this website. You just register so that we can give people credit and track. And we've had, actually, the first month we had more than 250 people outside of Del Med, so nationally that had accessed the, actually registered and went through the curriculum. And we've had folks like Hopkins has a HighValue Practice Academic Alliance, which is a national program. They have 82 residents and fellows from across the country that are are in their Future Leader program, and they've implemented this as a mandatory curriculum now, so they'll be going through it as well. My hope, and I share it, we are proud of it, but I share it because, 80% of you or so said you don't have anything there, and here's an off-the-shelf curriculum that really can be used at any level, can be asynchronous. You don't even need a local faculty champion. It can be self-directed, and we have more to come after this. And in fact, we've been in talk with the American Hospital Association on collaborating on some of these future modules and really making sure that we have some that focus on the hospital continuum of care and how we implement value in that, how we think about rural and critical access hospitals and their role in this. So those of you that would be interested in one day collaborating on that or sharing some of your stories as one of the care redesign cases, I would love to speak to you and think about how we could do that. One more off-the-shelf resource that I want to share that I've also been engaged with is we have a national nonprofit called Cost of Care that's been around for a bunch of years, developing resources for clinicians around affordability in healthcare. And so we've created some video modules about how you have conversations about value. So we have 4 modules. These are also free and available for CME credit, and they're available on our website. They're actually administered through the Doctor's Channel, which provides CME credit, and they cover how you have conversations with patients, how you talk about medication costs. Particularly for those of you in hospitals, I think the bottom 2 are particularly relevant. One talks about teamwork, how you have conversations between nurses and physicians and patients that relate to value and overuse. And then the last one, how you have conversations with supervisors and consultants. So shows a trainee talking to a neurosurgery fellow and then talking to her attending, and tries to highlight how we can have these conversations and teach very specific skills around this. Each of them feature Choosing Wisely recommendations. So the Teamwork one specifically has Choosing Wisely recommendations for hospitalists from SHM and from the American Academy of Nursing. We need to bridge, however, from what they have learned. So we need to get this out of just online modules and lectures and courses into what trainees and what our clinicians actually do. And so something we've implemented here had been developed by Eileen Moser at UPenn and a group at ACP, is called SOAP-V. And what it is a tool to help guide oral presentations, to build value into a cognitive forcing function for medical students and trainees. And the idea is when a medical student is presenting, or really any clinician, here we've expanded it from our medical students to our residents, and have been talking to our hospitalists about this as well, that when you present a general SOAP presentation, you end with a value component where you essentially ask yourself 3 things. Will this change management, and does it incorporate evidence? Have I considered the patient's goals? And what is the cost actual relative of the test or treatment? And by having that be a part of the standard note, students have an opportunity to put this into practice, to think about areas of overuse. It forces them to recognize issues like Foley catheters that could have or should have come out, transfusions that perhaps are not warranted, daily labs that were ordered, on admission QAM for forever. And so what we've seen is by opening up those conversations, medical students actually are managing up because they're bringing up these topics on their team to others, and it's a very simple model. What we did, by the way, at Del Med was we've implemented this to not just medicine, but all of our core clerkships, and we created pocket cards with this SOAP-V model that we gave to all of our trainees and our hospitalist attendings to remind them of what are the components to ask themselves for value. And as we try to activate and move upstream, another opportunity to do that is a program we're launching called Choosing Wisely Stars. This is based on a really successful model that was done in Canada. So Choosing Wisely Canada started STARS about 2 years ago. And what they did in Canada was they got 2 medical students from each of the 17 med schools. In Canada, it's pretty easy. I guess there's only 17 med schools in the whole country. So they get 2 students from each of those schools, bring them they brought them to Toronto that first year and did a summit where they taught them about leadership, they taught them about choosing wisely, and a couple other topics, and then sent them off back to their med schools, having created a learning collaborative. So they support them throughout the year, and those students implemented programs within their schools. So some started choosing wisely journal clubs, others started interest groups, others met with their curriculum planning committee and figured out how to get this integrated into their first year curriculum. And it was pretty amazing what the students had done that first year. And so we've decided to replicate that model here. And so we've got grant funding from Macy Foundation, the ABM Foundation, support from DelMed, Choosing Wisely Canada, and Costa Care, and we'll be having our Leadership Summit for medical students here in Austin on December 2nd. Our plan is to take 2 med students from each of 20 medical schools across the U.S., and right now we're actually collecting interested medical schools. We have a group of about 20, but there's still time. If anybody on the call wants to throw their hat in the ring, you should contact me and let me know your school is interested. And we want to select 20 schools that are diverse to have their medical students come, and we have the funding to pay for those students to come and join us. And so they will get education. We'll plug them into a learning collaborative. We'll have monthly webinars like this teaching them about examples around the country of what folks are doing around choosing wisely and teaching value. And we will follow what they do at their schools. And I think, and part of what we're doing is not just getting the students engaged, but also getting high-level support. So getting a faculty mentor and a dean locally at their schools who say they support these efforts. And this is a way to really implement this from the ground up. To make sure that we're spreading this message throughout our educational, throughout the country, educationally. So that hopefully gives you a few different opportunities and tools that medical schools, trainees, health professional schools can be engaged in. And that you can use no matter what level. So you can use this with your faculty or with your clinicians at your hospital. What I'd like to do is talk about how we're implementing this into learning environments or clinical environments more broadly. And so a program that we're launching, we are calling Bridges to Better Care. It's based on something that we had done successfully at UCSF, and there it's called Caring Wisely. In fact, we actually just had under the leadership of Ralph Gonzalez, who's the Chief Innovation Officer at UCSF, just in this month's Journal of Hospital Medicine, is an article describing Caring Wisely and the first few years of our program and success. So if you want to read more, that's available in Journal of Hospital Medicine this month. And the idea behind it is fairly simple. We crowdsource ideas from the front line. We get the ideas about how people can improve value within the hospital. The concept of this is fairly simple. Many of these programs in the past have really happened or currently really happen top-down, right? We see an opportunity, we say, well, we're going to decrease unnecessary transfusions or we need to decrease surgical supply costs, and then we push out some sort of program. And if you look at UCSF, you know, I ran around on a 15-floor hospital taking care of patients with folks. If you were to take the elevator down, cross windy Parnassus Avenue, go up in the next elevator to the 5th floor where these beautiful offices with views of the Golden Gate Bridge. That's where our administration sat, and that's who made policy. And a lot of times, I mean, they were great, wonderful people, but a lot of times there's a disconnect between what's really happening on the 14th floor and the policy that's being written across the street. And so what Bridges to Better Care is meant to do is quite literally bridge that divide. You know, here it's the same. Here our administration offices are all the way across town from the hospital that I work at. And so we want to bridge that divide. And what we have found is by crowdsourcing, by asking everybody in the hospital, clerks, medical students, nurses, physicians, researchers, anybody engaged in that health system, tell us your ideas on how you can improve value for patients. We collected so many ideas. We got more than 70 ideas in each of the 4 iterations that we did at UCSF. The first year we had, I think, 150 ideas. And the thing that I want to point out is, yes, sometimes we get ideas that are really brilliant that we didn't think of. A lot of times the ideas weren't necessarily something that the administration wouldn't have thought of, but the fact was you got engagement. You got 70 people to go on and be engaged in this work. And when the message from the nurse on the orthopedic floor is, I think we can decrease unnecessary blood transfusions, our experience was that it actually resonated much better than when that message came from our CMO. And so we did projects like that. The other key here is that while we're crowdsourcing ideas, we're choosing the ideas based on criteria and based on strategic priorities. So it's not necessarily a crowd voting platform. We match the ideas and enthusiasm from the front lines with the priorities and strategies of the clinical enterprise. And so we create a low barrier to entry. We then pick the best ideas and we invite them to develop a multidisciplinary proposal on how they would implement it. And a lot of what we do is this is iterative. So as the centralized team and as the director, I would look at the proposals and help make connections. Like, you really need a nurse on your team, or let's talk to this person, or I'd go to to the person in charge of our EHR and say, hey, is this idea even feasible? So we did a lot of vetting for these ideas. And then we chose up to 3 of them each year to implement. And what was done at UCSF was we gave, the medical center actually gave up to $50,000 funding for each of these projects. And what that money did was it paid for some of the clinician time to help lead it, but this wasn't a grant program. And in fact, in the 2 years that I helped direct, none of the programs actually spent all $50,000, and which seems surprising. But really it was because the message was, this isn't a grant program, and we provided a lot of the centralized support they needed. We had our own data person who could pull data for them from the EHR. We had our own implementation scientists. We did a lot of that centralized work so that the people from the front lines could be the leaders, the champions, and could be out front messaging, but we helped provide the institutional learning and expertise. I want to make this concrete. So let's see if I can get this slide to advance. Oh, there we go. So we got trainees involved, and so I want to show what that looked like. Karina Zygarakis is a UCSF neurosurgery resident. She actually just graduated.